Autoimmune diagnoses change all the time. Sometimes symptoms change, making a diagnosis more clear. Sometimes the actual condition can morph into something else. And sometimes a fresh pair of eyes can tease apart two conditions that look and act like each other. That's what happened with my patient, Tammy. Her story showcases the trouble we all have when telling rheumatoid arthritis from a similar condition, CPPD. So today, I'm going to tell you about Tammy, and along the way, we'll discuss what is CPPD, what are the symptoms, and how they differ from RA, and how we treat it. I'm Dr. Elizabeth Ortiz, and this is Connected Rheumatology. Let's get started. So Tammy, which y'all should know is not her real name, came to me after recently relocating to the West Coast where I was living at the time. She was a 69-year-old retired school teacher from Jersey and had moved west to be closer to her new grandbaby, which actually happened in LA a lot. Anyways, she and her husband had been looking forward to retirement and when not babysitting, spent their time cruising. She had been everywhere a boat could go. At 66, she had been diagnosed with RA, and although it would occasionally sideline her, she didn't let it get in the way of her travels. When I first saw her, she was pretty direct that she was doing fine and just needed a refill of her methotrexate. Yes, but I do need to examine you. And when I did, she was right. She was doing really well. So well, in fact, she had no signs of RA when I saw her. Her hands actually looked like the hands of someone with osteoarthritis. But that doesn't necessarily make me want to reinvent the wheel because you can definitely have OA and RA at the same time, and I just chalked it up to her methotrexate doing a good job controlling her RA. So I ordered some baseline x-rays of her hands and some labs, and I refilled her methotrexate. Her labs all came back fine, except for the positive rheumatoid factor, which she had had in Jersey, and I noted that her CCP antibody was negative. Her x-rays, however, again, were the x-rays of someone with osteoarthritis, not rheumatoid arthritis. But most interestingly, I saw a bit of calcification in the cartilage of her wrist. We call this chondrocalcinosis and can often be asymptomatic or associated with CPPD. Again, I had just met her. She's doing well and tolerating the low dose of methotrexate just fine, so I didn't see a need to rock the boat, but I did make a note of it. Well, it wasn't long before I did need to rock the boat, or should I say her boat was being rocked. While on a cruise, Tammy called the office in a panic. She was having one of her typical flares, as she put it, and her Tylenol just wasn't cutting it. She was almost crying on the phone as she described the pain and swelling she had in her hands and her knees. Being on a cruise in the middle of the Mediterranean is a less than ideal situation in order to do a full workup. So we advised her to get some prednisone from the boat's doctor. She did just that and finished off the cruise feeling much better, if not feeling a bit hungry, because prednisone increases your appetite. I saw her a week after she returned and she was great, like a little too great. I've seen a lot of RA in my time, and flares can certainly happen out of nowhere. But I had seen her a few weeks before, and her hands looked stone cold. And now, a week after a flare that was so severe that she was crying over the phone, her hands were again stone cold. The boat doctor hadn't given her that much prednisone. What more, she didn't seem that concerned, and frankly, seemed annoyed that I wanted to see her after her severe flare. For her, this was just par for the course. It was her rheumatoid arthritis. Always one to trust my patient that they know their body best, I noted my suspicions that her RA wasn't acting like a lot of the RA I'd seen before, but she seemed okay today, so we didn't do anything else. But then not even a month later, the same thing happened. This time, thankfully, she wasn't on a boat, so I had her come in right away so I could see what was going on with my own eyes. She had to be wheeled in because her knee was the size of a grapefruit. So I took out my arthrocentesis kit, And I took out 50 cc's of fluid from her knee, which isn't bad, and I sent the fluid to the lab and injected her knee with some steroids. Now, just in case you're not aware, arthrocentesis is the fancy medical term for sticking a needle in a swollen joint and taking out fluid. Now, steroids directly in the knee is a much more targeted approach to the inflammation that I saw in front of me, since the rest of her joints looked really good. It puts the anti-inflammatory medication right where it's needed, and it spares the person a lot of side effects like the increased hunger, insomnia, or jitteriness we can get with prednisone. Later that day, the results were in. The knee fluid showed calcium pyrophosphate crystals. The crystals that we see in CPPD, or calcium pyrophosphate deposition disease. So what in the world is CPPD? So CPPD is a crystal-induced inflammatory arthritis in the same vein as gout. Calcium pyrophosphate crystals deposit in our joints and can lead to severe acute inflammatory arthritis attacks, not dissimilar to gout, and in fact used to be called pseudo-gout. CPPD is not an autoimmune condition, and although the symptoms of joint pain, swelling, stiffness are similar to RA, it is a completely different beast that requires a different treatment strategy. CPPD is seen in about 4 to 7% of older adults in the US and Europe, older meaning the average age is 72 years old, and is seen equally in men and women. A diagnosis is confirmed one of two ways, either by looking at the synovial fluid of an inflamed joint and seeing the crystals, or by seeing calcifications in cartilage on X-ray. And now Tammy had both of those things. So I got Tammy on the phone when the clinic was over and talked about her results and the different data points I'd been collecting since we met. And before telling her that I was thinking she actually had CPPD and not RA, I needed to know one other thing. Had her symptoms gotten any better since starting the methotrexate? She was quiet at first, and then she admitted, no, not really. But I wasn't sure if I just needed more time for it to kick in. So it turns out that Tammy's arthritis had always been the way I had witnessed. It was characterized by severe arthritis flares of swelling, pain, and warmth that would respond to NSAIDs or prednisone, and then she would go back to normal in a week or two. She'd been dealing with this for about a year when she finally got in to see a rheumatologist. She had no symptoms when she saw him, but had a positive rheumatoid factor and told me that based on that, she was told she had RA and that she was started on methotrexate. She would have these RA flares periodically and just be treated with prednisone, and once was told to increase her methotrexate dose. I explained to her that what she's describing, of flares in between times of feeling perfectly fine, isn't really what happens in RA, and the fact that she had seen 0% improvement with methotrexate supports my theory that we aren't dealing with RA at all. In some severe cases, methotrexate has been helpful for chronic CPPD, but given her flares and the fact that she had never actually been treated with long-term anti-inflammatories like colchicine, I recommended starting a daily colchicine and tapering off the methotrexate. So that's what we did, and she did great. The number and the severity of her flares decreased, and even better, she didn't need to be on immunosuppressing medications like what we use for rheumatoid arthritis. This story, or some version of this story, plays out all the time in rheumatology. CPPD and RA can look very similar, and I always remind people that we make the best decisions we can with the information we have available. But Tammy's story is a reminder that we need to keep paying attention. If something doesn't seem right or treatments aren't working the way you think they're supposed to, bring it up with your doctor and ask questions. It's true that most medications take some time to kick in. It's also true that it shouldn't take years. Tammy's diagnosis was based largely on the fact that she had a positive rheumatoid factor. This is a common autoantibody, especially as we get older. And if you want to learn more about how to think about a positive result, and if it means you have RA, I recommend checking out this video next. I hope you found this helpful. My aim is always to provide you with the autoimmune information that you need in order to make the best healthcare decisions for you. If that's your jam, make sure to subscribe, and I'll see you next time.